Next is Dr. Tanmay Gupta, going to present to us on patient-reported outcomes for satisfaction and spectacle independence with blended refractive surgery.
A very good afternoon, everyone. I'm thankful to the scientific committee for this opportunity. I'll be presenting a very impressive study, probably the first in India, about the patient-reported outcomes and satisfaction and spectacle independence with blended refractive surgery. So refractive surgery encompasses any procedure that corrects a refractive error. It is well recognized that refractive surgery has significant impact on quality of life and daily work, with benefits extending beyond spectacle independence. Today, refractive surgery has evolved beyond the stereotypical laser eye surgery with the advent of technologies like femtoLASIK, SMILE, ICL, and customized RLE. In spite of all the advancements, a good anisometropic patients are deemed unfit for a single refractive procedure. High myopia and anisometropia patients may have difficulty with fusion when wearing spectacles. A common practice followed by many centers is laser vision correction for the fit eye and contact lens for the eye unfit for LASIK or PRK. Which surgical procedure will be chosen for the eyes of anisometropia patients mainly depends on the level of refractive error. Due to the limit of the patient's corneal condition, laser vision correction has historically been chosen for less than 12 diopters of myopia, while ICL is the go-to choice for the more than 12 diopters. Previous studies by Sanders, Igraci, and Kami et al. Have reported the grouping comparisons of ICL and LASIK. The current study, probably the first in India, was objectively conducted to compare the patient-reported outcome of ICL implantation in one eye and laser vision correction in the contralateral eye and investigate the long-term visual quality and stability. A retrospective study conducted at ONK Raipur from Jan 22 to September 23. A total 25 subjects who underwent ICL, phakic IOL in one eye and LASIK laser in the other, or ICL in one eye and PRK in the other were reviewed. All surgeries were performed with the same surgeon. The ICL was used care group IPCL, and the MEL-80 excimer laser system was used for LASIK as well as PRK, where the optical zone was kept as 6 to 6.5 millimeter. A quality of life and patient-reported spectacle independence questionnaire was provided to patients who had undergone blended refractive surgery at 2 months of follow-up. The continuous data represented in the form of percentage and the categorical variables represented using the frequency table, where p less than 0.05 considered as statistically significant. Coming to the results, all surgeries were uneventful and no intraoperative complication was observed. Complete satisfaction level was noted in seeing the distance, recognizing faces across the street, watching television, driving a car by night, using steps, crossing the road, using public transport and employment or housework activities. While in some cases dissatisfaction was noted seeing the bright light or glare, seeing in the poor light or dim, appreciating colors and driving a car by day. Spectacle independence with blended refractive surgery was observed in almost 19, that is 76% of cases, while 6 cases, that is 24%, still needed ARC-coated glasses for glare and halos. Overall PROs and satisfaction was similar among all groups. Refractive outcome and accuracy were similar. Refractive outcome differences were not meaningful, and substantially fewer patients noticed glare and halo. No new safety concerns were reported. As we can see, almost like 52% patients said they can function comfortably without glasses or contacts all the time, whereas 48% said they can function comfortably without glasses or contacts most of the time. The satisfaction with vision without glasses or contacts was at 100%. So the different surgical methods for the correction of myopia among anisometropia patients are based on the principles of safety and efficacy. The long-term visual quality and stability of different surgical methods should be evaluated. In this study, we presented patient-reported outcome and satisfaction. No infection, pupil dilatation, or other adverse reactions were observed, suggesting that both ICL implantation and corneal laser vision correction are safe and reliable in cases with suitable indication. The visual image magnification rate and visual quality were drastically improved after blended refractive surgery. A study by Nicholas et al. Reports better quality of vision, stable refraction, high satisfaction score after 9 years in a patient treated for high myopia with one eye ICL and another eye LASIK. Another study by Roberto Zalvida et al. Reported better visual quality gains, short-term safety, and refractive stability. A study by Zunchen et al. Also demonstrated that ICL implantation and laser refractive surgery techniques are both safe and effective procedure for both myopia and suitable indication. The choice of blended refractive surgery resulted in a higher percentage of patients who were deemed unfit for laser vision correction being satisfied with near, intermediate, and distance vision. Overall, the fewer patient-reported outcome differences were not statistically significant. My few limitations were that we did not completely match the patients based on preoperative refraction and axial length. The sample size was small, and lastly, there was no evaluation of increase or decrease in high order aberrations. So my take-home message would be blended or hybrid refractive surgery is a reliable and safe method of achieving near spectacle independence in patients with high anisometropic myopia. Thank you.
operate both eyes after how many days gap?
We kept a gap of, sir, 1 day.
Only one day?
Only 1 day, yes, sir. Not on the same day.
Which you prefer first, ICL or LASIK?
Sorry, sir?
Which procedure you want first?
Which procedure? We usually we did the laser vision correction on the first sitting, and the second, the follow-up day, we did the ICL implantation. Because since it's an invasive procedure, we wanted to do in the modular OT, so we used to do it the second case, yeah.
How was the patient acceptance of this type of procedure?
Patient acceptance is growing since past 2 years, so patient acceptance is growing. With our own.
Because if you tell them one eye you want to do this, the other eye you want to do this. So
they definitely ask this is something really new that they are hearing. ऐसा कहीं नहीं होता है.
Is there any advantage?
There's definitely an advantage, sir. The stereopsis improves drastically. Cost is definitely a little on the higher side. With the ICL on one eye and the laser vision correction, the cost goes almost till 1 lakh rupees for a patient. But patients who are affordable, the stereopsis improves drastically for the patients who are affordable. And they're near.
Normally, we operate both ICLs. ICLs are available. So
yeah, ICLs are available, but why to go for an invasive procedure when you can do the laser vision correction in that eye, if it is fit for the laser vision correction?
So both the eyes that way were fit for laser vision correction?
No.
As far as the pachymetry is concerned?
No, sir. As far as the pachymetry is concerned, as far as the corneal topography was concerned, one eye was unfit for laser vision correction, both LASIK or PRK. So we implanted ICL in that eye, and we did the laser vision correction in the fit eye.
they have anisometropia and one eye is very high myopia.
No, but anisometropia doesn't mean that pachy will be different in two eyes, no?
Pachy will
axial length may differ.
Exactly, but
Maybe
we
more
have
than 10 in one eye and less than 10 in the other.
you are absolutely right. But with anisometropia, if even like one eye is -14 and the other eye is -7 or 8, so the residual stromal bed decreases in the patient with a high myopia. So it will go beyond 266 micron or 254 micron if we do a ablative procedure.
True, but how many cases you find like this? It's not very common.
We do a blended refractive surgery almost
How
once.
many surgeries you have done blended?
25.
In how long? In what is the duration?
14 months.
14 months. You
14
get
months.
so many patients.
We are getting so many patients, yeah.
Do you have any comparison between bilateral ICL and the blended vision correction?
No,
Patient satisfaction goes.
no, sir. We have not done
You
that.
have never done a bilateral ICL?
No, we have done nearly 250 bilateral ICL implantations.
In a patient with anisometropia?
In a patient with anisometropia, which was like both the eyes were unfit for laser vision correction.
Oh, she has a question.
Right. As I mentioned, there was some dissatisfaction noted for patients who were working little poor or dim light, and there was a few patients with glare. So definitely the contrast is an issue. Yeah, but the binocularity improves a lot, and even there's a cosmetic correction, because otherwise, even with the high index lenses, even if you correct one eye and you give contact lenses, still the patient will not be satisfied with binocularity. So binocularity improves a lot.
Yeah, that's the logic.
We prefer to go for a non-invasive procedure if we can go for it. Yeah.
Thank you so much.
Thank you, sir.